Good afternoon, ladies and gentlemen, wherever you may be in the world. I'm delighted to welcome you to the 29th episode of our program considering the COVID situation in the world. I'm Vernon Moore. I'm the trustee of the ASHK Society here in Hong Kong. And we are really privileged today to have with us Professor Manfred Green from the University of Haifa in Israel. He is a physician, epidemiologist, and professor of public health at the university. Now, just to give a piece of context to people who don't know, Haifa is in the north of Israel. It is the third biggest city, and since ancient times, it's been a very important port. And again, a bit of perspective. Israel is a country of a little bit more population than Hong Kong, 9 million, as opposed to perhaps 7.5 million. So there's a sort of little comparison can be made. And we, of course, also are a port. Now, Professor Green is a physician epidemiologist, apart from being the professor of public health at the university. And we're particularly privileged to have him here to discuss this because he can approach things from so many angles. He began his career in mathematical statistics, so he's very good at that. He has done operational research, both of them in Cape Town. Subsequently, he did a PhD at the School of Public Health in North Carolina, and he's also a doctor. So he can see this problem from many dimensions. So we're really pleased, Professor, that you're able to join us today. And I would invite you to make a presentation about the Israeli experience in dealing with COVID.
Thank you very much. And thanks to everybody for inviting me to this meeting. I'm very pleased to be with you and honored. I'm going to put up a presentation, give a short presentation, and then I believe we'll open it up for questions.
Mm-hmm.
Just want to check that you're seeing my presentation.
Well, I am.
Okay, if you are, I guess everybody is. Okay, great. Okay, so I'm going to give you a very short overview of COVID-19 in Israel and what we've been doing with the vaccine. So just to give you some perspective, we've had up to now about 850,000 documented cases and about 6,300 deaths. So actually the pandemic has been quite severe here. Maybe we will be somewhere in the middle of different countries, but we certainly had a considerable amount of morbidity of cases and of deaths. What we're seeing is this curve here. I know it's a little bit crowded and I couldn't get rid of those numbers. The numbers are actually the numbers of cases, but what you're really seeing is on the orange kind of thing, those are the new cases occurring, and then the blue line is actually the cumulative number. But the one that's really important is the kind of wavy pattern there. And what you're seeing basically, if you go right to the beginning of the graph, around about 12, 13, that's the week of the year. That was the first wave, and you can see that was a considerably smaller wave than what we saw afterwards. So we had a small wave in the beginning in March. We started a certain amount of restrictions, quite severe restrictions, and particularly in closing the airport to some extent, not allowing people from abroad to come in for a while. And then we gradually lifted some of these restrictions and particularly letting kids go back to school. And we saw a second wave, which almost looks like two waves because it was a small one and then a larger one. We went back into lockdown and closed things and basically stopped kids from going to school, closed all the stores, closed all big events. Obviously, we were by then introduced wearing masks and social distancing. And then we started to drop some of those restrictions, and we saw another big wave around about October, November. And that wave went on until the end of January, basically. In the meantime, we had started the vaccination program. So what I'll talk about now is that the vaccination program basically started in the middle of this third wave, the so-called the winter wave. Just to show you very quickly that these were the death rates, and they are comparing death rates over a period of years, the red line being the variation, basically the weekly variation in death rates. And you see basically peaks in winter, which we have because typically of a country which has winter, not like Hong Kong, maybe, where you have double winters or double summers, whichever way you look at it. But we have a single winter, and the rates go up generally in winter. But if you look at the right-hand side of the graph, you'll see those peaks there, and that's the excess mortality that we saw from COVID-19. So COVID-19, it's just not 6,000 deaths that were recorded as COVID deaths. We can see it in the excess mortality, which more or less parallels the number of COVID-19 deaths. The vaccine that we've been using in Israel is the Pfizer-BioNTech mRNA vaccine. And I think you're all familiar with it, but I'll just say a word about it. The vaccine is it is a dramatically different approach to vaccines. We don't have many changes in the technology of vaccine, but this is certainly a change in technology, basically taking a synthetic part of the virus. In other words, taking the mRNA, not the genetic makeup of the virus, basically, but the mRNA, which is what transfers the information from the so-called RNA of the virus. And that's made synthetically based on a knowledge of the genome of the virus, genetic makeup. And then that synthetic part is actually injected, covered in a small kind of what we call lipid sheath or fat sheath, and that's injected into the person. And that actually enters the immune cells of the person who's being vaccinated and encourages the person to actually generate a protein part of the virus that doesn't do any damage on its own, but it does cause the body to produce antibodies against that, and that basically produces antibodies against the virus. That synthetic part, by the way, the synthetic RNA, gets broken down and eliminated from the body in a few days. So it's a very nice and very new way of vaccinating. We started a major vaccination campaign, and the vaccination campaign started like everywhere else. We started first with the healthcare workers and the elderly, pretty much over the age of 60. We had a fairly broad range. And we vaccinated people, and you can see those are the weekly data, the bars. But if you look at the blue line there, that's the number of people who have received at least one dose, and we've gone up to over 5 million. And the red line is the number of people who've received at least 2 doses. It's a 2-dose vaccine. So basically, we got to very high levels within a population of about 9.2 million. And of the eligible, because we're not vaccinating children under the age of 16, and only started recently doing the 16 to 18. So basically, you can see that the 5.3 million first doses, and that's about 74% of the eligible, and 4.9 second doses, which is about 62% of eligible. So a very large percentage of the eligible population, meaning now anyone over the age of 16 has now received at least 1 dose, and a large percentage have also received 2 doses. According to the age group, if you just look at these green bars, so this the light green, basically if you look at the dark green tip there, that's the number of people or the percentage who've received at least 1 dose per age group. So you can see that in the older age groups, we have very high coverage, 70, 80, 90%. And not only for the first dose, but also for the second dose. And as you're probably familiar with, most of the mortality, most of the deaths for COVID-19 are in the elderly people, certainly in the 50 to 60 above. So that's had a dramatic effect on the deaths in the country. So we can look at the impact. And if you look just recently now, the number of deaths started to go down very dramatically, as you may have started to notice in the earlier graph. But here you can see in March, April, we've been going from numbers where we were at 6,000 or so cases a day. We now at about 150 cases a day. So the number of cases a day has now dropped dramatically. And the severe cases are dropping also. Remember that severe cases follow the new cases, so it takes a little while for them to drop. These are people who are hospitalized, but you can see this is dropping dramatically. And in fact, now from having maybe well over 1,000 people hospitalized for COVID-19, we now around about 300 people are still hospitalized for COVID-19. And then the deaths, you'll see, well, there's a lag, it's going to take time. But this is only in the last couple of weeks, but previously we were seeing maybe 40 or 50 deaths a day. And now we're dropping to 3 or 4 and sometimes even 0 a day. So we really have, the vaccine has impacted on the cases, on the severe cases, and on the deaths. This is just another way of showing it for different ages, where if you look on the left graph, basically the light blue and dark blue show the percent being vaccinated, and that's over a period of a month up till February, and you could see already the impact of the vaccine. That's the yellow line there. You can see there, we started to see that very rapid decline in the number of cases. This was the age 60 plus, because they were the first to get vaccinated. The number of hospitalizations, or the rate of hospitalizations, dropped dramatically. And if you look at this one here, you can see that if you compare 2 age groups, the top line is basically the orange one, is basically the people over the age of 60, and they have had much more disease and hospitalizations, basically, not much more disease, but much more hospitalization. So they were way up there. And with the vaccine, because they were the first to be vaccinated, it started to drop dramatically. Whereas those who had not yet been vaccinated, those were under 60, it was still going up. Now all of them are going down. So you can see that this is very good evidence that what had been happening is not just a change in other factors, let's say social distancing or lockdowns. This was really the impact of the vaccine. This is the R that everyone talks about, and you can see it goes up and down. And this is just recently, but our R was well above 1 for most of the pandemic, sometimes reaching high numbers. And basically now, even with the lockdown being lifted, we're well below 1. It goes up and down. I know there's a little bit of an increase. That was when we stopped the lockdown. But still, it's still well below 1, which means that the pandemic or the epidemic in Israel is actually declining and seems to be going in the right direction. This is just another, if you look at, again, try to ignore the green ones, that's actually the number of tests being done. But if you look at the number of tests that are positive, and you look at the red and the blue line, look particularly at the red one, which is an important one. That's the one that's actually cases who were identified not just by surveys, but because they were symptomatic or whatever. Then you could see that the percent positive in the test has also been dropping very rapidly, meaning that people who have symptoms of something that resembles COVID is now much less likely to be COVID-19. And that's another indication of this decline in the rates of the disease. So the question really now is, what is going to happen to COVID-19? And I'll just put down a couple of them. I think the concern are the mutations. There are the British mutation, South African mutation, Brazilian mutation. These mutations are slight changes in the genetics of the virus. The virus is an RNA virus. It replicates and makes mistakes when it replicates. And these mistakes sometimes get amplified, and then the virus changes slightly. And the problem with that is that it may then impact on the efficacy of the vaccine, because if you get a vaccine against one kind, you produce antibodies against that particular virus. So if that virus changes, your antibodies may not be that effective. Fortunately, with the Pfizer-BioNTech vaccine, it's still very effective both against the original wild strain, the British strain, and also the South African strain. They've shown that it's still effective against the South African strain. So at the moment, the vaccine is working well against all the known strains that are around, but we are concerned, obviously, about more changes. And this will bring us again to the questions, because the more people we vaccinate, the less there'll be circulation of virus, the less possibility is that there'll be changes. So it's very, very important that all of us, and when I say all of us, I mean basically the whole world, basically gets vaccinated. So some of the questions, and this we'll leave to question time, but I'll just put a few of them up just as a pointer. The one question, of course, is how long will the vaccine immunity last? At the moment, we're only promising a few months because we don't have data longer than that, but we do believe that it will last much longer than that. That's not our knowledge of other vaccines. So although we say that at the moment we only know that it can produce immunity for 6 months, that's the experience we have because we only started to vaccinate in about November. So we just accumulating time. I guess we'll update that number in the next few months when we see that in fact the vaccine is still effective. But again, I have to admit that we still need to wait for that data. But it looks like a very effective vaccine. We know that it's producing very strong antibody response and what we call neutralizing antibodies, which actually neutralizes the virus. If there are significant mutations, we may need new vaccines. And in fact, with the BioNTech technology, it's relatively easy to produce new vaccines against the new variants. It can be done pretty quickly. Within a couple of months, you can get new vaccines out. So the companies are obviously working on that. And it's the same kind of concept that we do with influenza, updating vaccines. Although here with the new technology, it can be done much more rapidly than with the flu vaccines. We may have to repeat the vaccine periodically if we do see that there's a decline in antibodies and that there is so-called breakthrough, that people who have been vaccinated start to get infected. And that means that we may, like many other vaccines, we may have to give more than 2 doses, maybe 3 or 4, maybe it'll be annual or every 2 years. We still don't know. I mean, we're still learning about it. It's clear to you that our experience of this virus is only the 1 year, basically, just a little bit more than a year. When it's been spread, what I'm talking about, when it's spread widely. So we're learning. The compliance of the public is going to be a major issue. And I know that this is something we'll talk about. I've heard something about Hong Kong and that the compliance there is perhaps not so high. So we have to look at why there is a lower compliance amongst the public in some areas, in some subpopulations. What is causing this so-called vaccine hesitancy? And basically, I asked the question, do we need to vaccinate the whole world? The answer probably is yes. It's just like measles or rubella or polio. We really have to get the whole world vaccinated in order to control this pandemic, unless there's some surprising change in the virus. But at the moment, that's really the prediction that we have. The question really, the last thing that I'll say is, can this virus be eradicated? It's very unlikely. We've really not succeeded in eradicating viruses unless, of course, we have a very high compliance with the vaccine. The only virus we've ever eradicated is smallpox, and we're still trying hard to eliminate measles, polio, and rubella. We're making good progress over in the world, but that's due to very high immunization rates. In other words, vaccinating worldwide 90–95% of the population. So at the moment, we can keep the disease at a manageable level. But again, I say, really, vaccines are the only real solution if we're going to open up the economy and open up the society. Because once there's movement of people in and out of the area, the country, and so on, that's obviously going to be dangerous for producing outbreaks of the disease. We think it might become a seasonal disease. In other words, it'll occur in the colder months, and hopefully maybe causing a milder disease, which we sometimes see with some of the influenza viruses. And again, we may need periodic vaccination. So basically, now is the time. We need to buy time. When I say buy time, we need to vaccinate and maintain the disease levels at very low levels in order to avoid this problem of variations or variants or mutations. We need to slow down the panic, and the big message, I guess, is get vaccinated and be prepared for the next pandemic. So thanks very much. As everyone is saying now, no one's safe until everyone is safe. Thank you very much.
Well, thank you, Professor Green. That was really quite fascinating. And we can see from the statistics that Israel has done a wonderful job with vaccination. You're right at the top of the list of vaccinations per unit of the population. And congratulations. Now, one question which I think is on everyone's mind, was the first question which has arrived, is what did you have to do in Israel to encourage people to get vaccinated? Was it easy? Were the special techniques done? I believe some sections of the community were, even in Israel, rather reluctant. So people are interested in understanding what you did to be so successful.
Right. I have to be honest and say that the first thing was to get actually vaccine supplies. And Israel took out options on a number of vaccines early on. So the Israeli government did actually take the risk, so as to speak, of actually taking out options on vaccines that either had not been proven to be effective, or we didn't even know whether they would be produced. So this is obviously a risk, but it was a good risk. And I think this is something that we need to learn about. There's basically no choice when you're in an emergency. The other thing was that we have a very centralized health system and a very good program of vaccinations generally. They are given largely in the government vaccination centers for children, and also in the so-called health funds. Everyone has to belong to a health fund. There's no compulsory immunization in Israel, but the compliance is very high, well over 90%. So for the routine one. So the population is used to the concept of being vaccinated. But I think there was a successful promotion of the vaccine, that it was safe and effective and basically the only way to get out of this pandemic. So I think this was a message that got through to most of the population. But as you pointed out, there was still a lot of suspicion. And we still have some of it. Early on, we had a lot of it before the vaccine. In fact, the usual one was let somebody else get it first, sort of thing. That we always also say, who's that somebody else? Your neighbor, your cousin? Who is that person going to be? But that's a typical reply. But once people started to see others getting vaccinated, and there didn't seem to be any real problems as the rates went up. There are subpopulations. Some, I say, in the ultra-religious Jewish community, in some of the Arab population, where there is suspicion, and I think we spoke about it earlier. Some of it is partly related to mistrust of the government. So I think it's a combination of things. But there is, and a lot of misinformation, which you want to talk about. There was a huge amount of misinformation on the social media about the dangers of vaccines.
I see. Another question which has come in, which is sort of related to, in a way, to the vaccine, is you chose to use one vaccine, but you said earlier that you ordered other vaccines. And so why did you choose this one? I mean, how was the process of choosing?
Well, this is a controversial issue because it's become a little bit political also. Basically, I think that in the negotiations, unfortunately, the professional people like myself and others were not involved in negotiating, and neither with the companies and nor with the costs and so on. But I think the negotiations were more or less along the lines that whichever company was able to give guarantees of large number of doses at a price which not necessarily was reasonable, may have even been a higher price, but the basic concept was we need lots of doses. So if you can guarantee that you can give us enough doses for our population, then we'll sign on an option. We'll actually provide money and take up options and produce, pay a lot of money for that. There is one negative feature in that, and I must add, and that is that it is a kind of, to some extent, a selfish approach. And we've been talking about this nationalism, this sort of vaccine nationalism, where each country basically worries about themselves. Because you can argue that a country like Israel or any other who takes, a lot of the vaccines because they managed to get in early and they managed to produce the money, are actually doing that at the expense of other countries who don't have the resources. So I think that Israel does have to be very active now in helping other countries. And I really believe it, and above all the Palestinians, which I keep saying, it's very, very important that the Palestinian population be vaccinated. And I really do see that as a responsibility of the Israeli government, together with others, WHO, but We have a responsibility, no doubt.
I also read that you agreed with the vaccine suppliers to provide a great deal of data to help them develop and refine their vaccines. Is this correct?
Yes, this is a kind of an unusual situation. The data actually is not actually data that is not available generally. It's data that the Ministry of Health produces anyway, and they would have produced it and analyzed it anyway. But there was, I think, an understanding, and not I think, I know there was an understanding with the company that there would be good follow-up and that there would be good data that would be provided. So I think it was more in terms of the quality of the data and the timing, and not that they were getting any kind of data that would not be available otherwise. They didn't get individualized data. In other words, not personal data. They got aggregated data. So in other words, in age groups and sex and so on and so forth, an area. And they have, in fact, there's been a publication now together with the company and the Ministry of Health. They've published an article indicating the efficacy of the vaccine. So I think it was right to do. I think the way in which it was done created suspicion, which was unfortunate.
I see. Another question which has come in is do you know if there are other vaccines being developed in the world? I mean, I suppose if this one is effective, we might as well stick with it. But this is a question from somebody who is listening.
Well, strangely enough, not so strangely, because this is such a huge event and so much money was put into this event, particularly by countries like the US and there's China and the European Union and so on. Many companies entered this, and it's probably about 200 vaccines are being developed. Most of them will never actually become used. They'll never be used because they don't reach the stage. But this is a huge development program. And there are a number of vaccines now that are available. So there's certainly the BioNTech, the Moderna, the AstraZeneca, Johnson & Johnson. The Chinese have 2 vaccines, I understand. There's Sputnik vaccine, the Russian. So fortunately, the vaccines, this is a virus where fortunately the vaccine, I don't say it's easy to produce, but it has turned out that it's relatively easy to produce vaccine that provide protection, unlike, for example, HIV, which has been a total failure, basically. We don't have a vaccine after almost 40 years. So, and for different reasons, because the virus is a different virus and a different issue. So basically, there are a lot of vaccines around, and probably most of them are giving good results. I mean, those that have been approved, certainly.
Yeah. A further question is about treatment. I mean, Israel's known as the startup nation, and I know you have a lot of people who like dealing with medical problems. Are there new methods of treatment that have been developed over the last year?
Yeah, it depends who you talk to, but basically there's no real medication that's been identified that's really been effective against COVID-19. Some of them seem to be effective to some extent early in the disease for some of the patients, some others, and the clinical trials have generally been disappointing. I think the most important thing is supportive treatment. And we do hear from our physicians who are treating patients that the earlier the patients actually come to the hospital, those who are with severe, the better the results. And in fact, we know that in some of the subpopulations, they've come to the hospital late, and that's been a problem. Once they go into that so-called almost kind of autoimmune, that place where they really have this cytokine storm or whatever, which actually is a reaction of the body, and not so much the virus causing the problem, but your body's reaction. That's very difficult to treat. So by and large, though, coming in early, and this was very much encouraged, having facilities to treat people, which was also something you had to boost your facilities very rapidly, and then giving very good supportive treatment, that certainly makes a difference.
Mm. Yes, I noticed looking at the statistics that the percentage of people who died as a percentage of the total who were diagnosed is actually quite low in Israel, although the absolute number may be quite high.
Right. Well, that's a deceptive number, and I'll tell you why, because Israel is a very young population. and the cases were very young relative to that. So in fact, if you compare, for example, with the UK, it wouldn't be fair to compare them just on a percentage basis. If you look at it per age group, then Israel is somewhere maybe a little bit, somewhere in the middle or a little bit better than that, but not the best. We taking into account the age of the population, the age of the cases, not just of the population. For example, just quickly, in South Korea, for example, they had big outbreaks in very young people at some stage, and that pushed their so-called death rate to a low level. But that was not because, it was just because the numbers were among young people. Under the age of 40, there is very little mortality. We have very little deaths under that age. We have some severe disease, but very little deaths, very few deaths.
I suppose that, I mean, actually just looking at numbers so early is perhaps a mistake. I mean, we won't really know, people like yourselves won't be able to analyze the different effects on population and treatment, etc., for maybe 5 years. I mean, it would be a complex business.
Well, I think what you're talking about is the so-called long COVID, the long-term effects of the disease. And we need to divide that. Those who have suffered severe disease certainly could have long-term sequelae. Those who had very severe disease, we know, will have, many of them will have severe lung problems, which will require treatment for a long period of time, including we've had now cases of people who've had to have transplant, lung transplant. But that's in the extreme cases. Those are the really extremely severe cases. We still don't know too much about the others, and we are doing studies on that, and one of them I'm involved in, or two of them, in fact, that I'm involved in following up patients. So we basically are interviewing patients months after the illness and getting information on how they're doing. And there is some information now in the literature that there's still a fair percentage who still complain of fatigue and of cough and feeling, not feeling well. But we need more data on that.
I believe in Israel, because of the success of the vaccination, you have relaxed some of the requirements for things like going to theatres and coming into the country, even if you have been vaccinated. And we have a question from Rachel Chen, in fact, who says that, what do you think of the implementation of vaccine passports? Are they a good idea? The US, she says, has decided not to use it. So how's been the implementation of giving, you might say, almost an incentive to the population? If you get vaccinated, you get a benefit.
Well, first of all, I think we need to talk about vaccine passports from the point of view of internal movement, and that's, although the passport always has the connotation that this is between countries, and then the international aspect. From the internal point of view, that each country can really make a determination on that. It's not unusual for us to do something like that. If you think about it, we do in some senses we require children entering, let's say, grade school or whatever, to required to demonstrate that they've been vaccinated. It depends where. We still are working on that issue, but in the US, for example, that's required, and it may well be required in Hong Kong. So that's an issue where you can actually have a vaccine passport on one condition, obviously, because there is this problem of fake passports. In other words, so we need to have a good barcode system, which is very sound, and that people will not be able to, and places will be able to identify. The question of international passports has raised an issue of the inequalities, because what we're basically saying is that if you live in a high-income country and you've had access to vaccines and you've got vaccinated, you can then travel to low-income countries without any problem. But if the low-income countries don't have the facilities, they're not allowed to travel because they don't have the facility. And that's going to create huge inequalities. So I think that we need to now work on a situation where we really have to get people, we have to get to a situation that anyone who wants to be vaccinated can get vaccinated. Then the vaccine passport will be much easier to implement. Until then, it's going to have some problems with that, some issues that we need to determine. Because it is going to be difficult to turn away people. You're basically going to say no one can enter your country unless they've been vaccinated. And then you're basically saying low-income people will not allow to come into your country. And that's going to create a certain amount of tension.
Yes, I think that's understandable, but isn't it almost the same as countries saying you must be tested before you arrive, unless you come from a rich place where it's easy to be tested? I mean,
well, until we get to these very high rates of vaccination, I think the testing is it's a very good procedure, and I think it should be done. So I think this is more and more we're going to combine it with testing. Testing again is limited. By the way, the vaccine is not 100% effective either. So I mean, we'll still have a few breakthroughs there. But testing, we have to make sure that it's a testing procedure that's going to be sensitive enough to make sure. Because if somebody is not as negative basically a day or two before they leave, they can certainly become positive later. You test them again when they come into another country. So you're putting in all these checks, but I think that's an area which we need to improve, and certainly that will help. That will help.
Yes. I mean, I'd always thought that it would be really nice if there was invented a test which you could sort of, when you brush your teeth, you happen to tear it off and test or something. But then people could do it as a routine. And but I suppose,
well, they've started to produce that. This is in production now, a home self-test. Again, the question is getting it to the level where it's sensitive enough, basically, to pick up where we know that the person has actually taken the sample correctly. This is one of the issues, obviously. Do you trust the fact that somebody took a good sample, applied it correctly, and so on? But these are things that are being done right now. Yeah.
Oh, excellent. Well, look, now let's change the direction a little bit to or what lessons can be learned. This again is a question that has just arrived, and it's obviously quite central. I mean, what have we learned in a year about managing this sort of situation, which could occur again, I suppose, tomorrow? I mean, about how you should deal with your population, should you contract tracing, etc., etc. I mean, what lessons have we learned that we can apply in the future?
Well, I guess the number one is that we need to have much better preparedness. We weren't really prepared for this kind of pandemic, and we recognize it, even though we've spoken about it before. But in the past, we've often spoken about pandemics such as pandemic flu, where we knew or we believed that within a few months we'd have a vaccine. We didn't really, I think, prepare sufficiently for a pandemic where there was no vaccine and it had to be produced de novo. There was basically, and it's pretty amazing that we do have vaccines so quickly. I think I think it would be correct to say we had some good fortune there. I mean, there was some luck in that. It could have gone the other way. So we need to work very hard on that. We need to increase the capacities now for producing new vaccines quickly. And that was to some extent neglected because it probably wasn't very economic for the companies. So governments and international organizations are going to have to work out a way of making sure that these production facilities are available at short notice, and the development facilities, in other words, producing new vaccine, has to be improved dramatically. The other thing will be that each country has to basically then improve, particularly the surge capacity in their hospitals, where we saw the tremendous breakdown early on and the very high mortality as a result, because people just couldn't get into hospitals because there was no space. So that has to be worked out, and worked out in a way that's feasible and also not too expensive, because we can't impose on countries that are low-income countries to invest huge amounts. But I think we can produce adequate hospital facilities that can be expanded rapidly, at least at a certain level, not pay much.
So we have a technical problem.
Really have to work very hard to share information. And I know there's a lot of issues about whether China provided enough information early on, but it's not just China. That's ignoring the possibility that many countries are not really providing, most of us are not providing information, or we're not looking carefully enough for these kind of incidents, or we're not transmitting the information quickly enough and in a detail. And we need to do that. And there's still a relatively poor exchange of information. That's a good opportunity, by the way, for the people in the field of information technology. We have to improve that dramatically.
I see. But how about things like the reactions to if a new disease arrives today, what about the procedures? I mean, did you think the procedures for contact tracing, for quarantine and the like have been successful or could be better made in some way?
You know, we had plans set out in a number of countries, certainly WHO and CDC in the US and others. But first of all, there was very little exercising of these plans. Somehow these were considered to be rare events, and my feeling is that we certainly didn't exercise them enough. For example, the whole debate on the use of masks should not really have been a debate that started during the pandemic. Masks have been debated way back, but we didn't try and get to some kind of conclusion. So it remained something that was, an unknown sort of thing or not clear. And what happened was that once that issue started, you realize there was this huge controversy, and eventually there was this encouragement to use masks. I think that would have been, the use of masks could have been introduced much earlier. And I think that was done, by the way, in countries like China and maybe Hong Kong, China and Taiwan and so on, where it was more customary and to use masks. And it was done on an empirical basis, maybe, but it was a good decision. In many of the other countries, the European countries and so on, it took a long time to actually get this to be implemented, the social distancing. So those are the simple procedures that, in fact, should have been in place early on. And then, of course, the third thing is, which is the complicated one, is closing of borders. The general consensus before that was that closing borders should be a very, very extreme action. But it does, I think, need to be revised. I know that WHO tends to say that closing borders may create more problems than it actually solves. But I think we don't have a good solution to that. And the countries who closed borders, such as Taiwan, Hong Kong, maybe New Zealand and so on, they were successful and they kept the rates down. And then later on, we've seen now what countries are closing borders, and this has become almost acceptable. So we need a new consensus on the border control, which is still not clear.
Yes, I mean, speaking for Hong Kong, I mean, people remembered SARS. I think this is the observation I would make. I mean, the moment people heard about the 3rd of January was this potential problem, people started wearing masks on the street in Hong Kong. And nobody asked them to. They just got on with what was sensible. I mean, I suppose that's what you'd like everyone to learn around the world.
Sure.
Yeah. And
yes.
Yes. We have another question here. What will be? I mean, you did research in this area. What is going to be the direction of your research in the next year or two as a result of COVID? Is it going to change, or what's it going to be?
Well, one area clearly is this post-COVID one, which is related to long-term effects of diseases like COVID-19. So it will be not just on COVID-19, but generally, what do we expect from that? Certainly, I've been in the past involved in vaccine testing and so on, so maybe I'll be involved a little bit in the area of response to vaccines. I don't deal with vaccine development, but more to testing the response to vaccines. One of the areas that's of particular interest to me are individual factors that are related to the response to the vaccine and also to the disease and side effects of the vaccine. So I think that we need to understand much better why some people suffer from side effects and others do not, or some people suffer from more severe side effects, and why some people suffer from more severe disease. So I think that will be the area that will be, personally, the area that I'll be looking at individually. I think that just from a methodology point of view, I think that certainly I'd like to be involved in the development of better information systems for epidemiologic studies, how we can get better information and use that information in a timely manner. So that will be another area that I'll do. Clearly, the big areas that will be vaccine development. I mean, that's going to be, I guess, a huge area now. because I think that the vaccine now that's been produced for COVID-19, particularly the BioNTech and Moderna methodology or technology, is probably going to be a basis for new technologies for other vaccines, for other diseases, which we have now. And in fact, we haven't made a lot of progress in new vaccines over the past number of years. So I think this could well be a breakthrough. So that's certainly going to be a big area. And then the last one, which I shouldn't ignore, and I think this is an issue that we wanted maybe to mention, is this whole question of the attitudes of people to vaccines. Why are people afraid of vaccines? Or why are they hesitant about taking vaccines when they don't seem to be hesitant about taking medications? And the side effects of medications are usually much more severe than those of a vaccine. So we need to understand this better and to understand what kind of information people need and how this should be transmitted.
Yeah, that's interesting. You answer another question, which is exactly that. I mean, what is the reaction of people to vaccines, and why does, in some people, is there a negative reaction? I mean, it seems that most people don't worry about taking their kids when they're very young to get the compulsory vaccine. So I wonder why the questioner is wondering why do adults feel more worried than for their children? Perhaps there's no answer.
No, there's something mythological almost about vaccines, because if you think about it, basically people will take multivitamins every day. They'll buy them in the pharmacy or in the drugstore or in the supermarket, and they'll be swallowing these pills regularly without really concerning themselves with what possible side effects they could have. When you tell people that you're going to inject something into them, I think this has a kind of a connotation that this is going to be more dangerous or more. In effect, if you look at it carefully, it doesn't really make too much difference if you inject it or you swallow it. So, but there is this concept that you're injecting something into healthy people. And this is always a concern, although vaccines have a very good safety record, generally. I mean, it's very rare to have very severe side effects of vaccine. There were vaccines in the past that we had, except when there was a very severe disease. For example, the smallpox vaccine had some very severe side effects occasionally, but it was still used internationally and almost universally. And I guess maybe you can argue that there's been a change in the way in which people think over time, a new generation who are more suspicious of what's going into their bodies or whatever. But this is something we need to deal with. I think it's related, I think, to this, kind of move towards less unnatural things being put into your body, although everything even the natural stuff is to some extent unnatural, or whatever you want to call it, or the other way around. So I would say that this is something that we need to understand much better. The misinformation, though, is one of the major issues. I'll just mention one of them, and that is that the vaccine can cause some effect on fertility. It has an effect on both in male and female fertility. And that actually is not new for this vaccine. This is a concept or a myth that was introduced years back, for example, in Nigeria, where it was spread as some kind of rumor that the Western powers were actually using the vaccine that was being introduced for polio, for example, to actually reduce the fertility rates of the local population, which had no biological basis and no other basis, but it became a common myth and people refused the vaccine. And you're hearing it even now for this vaccine. I mean, people often say to me, well, what about the long-term effects of the vaccine? Well, why would there be a long-term effect of a vaccine? I mean, you could say there's a long-term effect of anything, certainly of any illness. But the vaccine, basically, all it's doing is stimulating you to get antibodies. Now, you can argue that some of them have argued about this autoimmune disorder, but really you don't see it virtually. I mean, it's not that it's impossible, but it's so rare that it's really not something that should be a concern. I do think, though, that we need to work on vaccines that have less side effects, because side effects do worry people. And any of these, and the AstraZeneca story is a problematic one, because even though it's a rare side effect, it took quite a while for the vaccine people and also for the regulators to agree that it might be related to the vaccine. And I think concerns people. So you say, but it's very rare. So, and then there's this change that maybe it shouldn't be given to women under the age of 30 because, so that, this is something that will happen all the time and create more concern amongst the population. So we need to deal with these concerns.
Right. Now, you mentioned smallpox and polio, and it took a long time to sort out. I mean, from the time, in modern time anyway, that people attacked smallpox, I think it took 30 years to pretty well eliminate it, and polio maybe a bit quicker, but still you're talking 20 years. And so and both of those required leadership. I mean, somebody took the cudgel to get it done. And so I just wondered what you thought about the World Health Organization's organization. As I understand it, basically they have to get consensus amongst people to make decisions, which may be a bit of a problem. So how do you think the world, or what role should they play, and how would you change that organization to be more effective?
Well, first of all, as you say, they were very effective with the smallpox campaign. Smallpox being a little bit easier because it's easier to detect a case. You actually see the symptoms, and it's not like SARS or COVID-19 where a high percentage of the patients are not symptomatic at all. So then they can still spread the disease. So it was easier to contain it. But there was a decision in the 60s that the world should get together and actually find a way to actually eradicate smallpox. It was D.H. Henderson and others, it was kind of a new concept of eradication. It wasn't thought as being feasible. And that introduced a huge campaign, basically trying to identify cases all over the world in the smallest villages and so on, and then vaccinating around them. So it wasn't so much a mass vaccination campaign in the sense that everybody was being vaccinated. They were basically identifying cases and vaccinating around them and then containing these outbreaks. The next stage was basically polio and then measles and rubella. Polio has been going on for a long time, and the attempts to eliminate are almost there. We've met two problems. One of them is that the polio in the vaccination campaigns in Afghanistan and Pakistan are still stalling because there are some political issues and they haven't been vaccinating as they should. And that's partly due to issues that, some of this anti-vaccination. So we still have cases there. And there's another issue related to the old oral polio vaccine, where we are still seeing cases due to a change in one of the components of the vaccine. But that was a live vaccine, not anything like the vaccine that's being used for COVID-19, where it could undergo change and it's still being spread in some parts of the world. So we're still working very hard to get rid of polio. The measles one is another one where we should have got close to it, and measles is, and that's also being led by the WHO. Again, it's being impacted by vaccine hesitancy in certain subpopulations. And maybe we still need a better vaccine, even though that vaccine is 97% effective, but it requires 2 doses and all the rest of it. So maybe it'll be a combination of that. But I think WHO is still working very hard on that and working very hard on rubella, which has also been reduced very dramatically. So the question now is, as you pointed out, was that the WHO works on consensus, and they have, I always forget the number, but maybe at least the number of UN members, close to 200 member countries and territories. And all basically have to agree to be in the program. I mean, you can't have 1 or 2 who disagree, then you're in trouble, because then you have these pockets. So I think that this is where WHO is going to have to show very strong leadership. And I guess it will be a combination again of trying to broker the kind of disagreements between the different countries where there are issues. I think there should be a lot of consensus. Once there will be enough vaccine available, then of course that will make things much easier. And then we can say, okay, anyone who wants it can get it, and then you can implement these widespread programs. But again, WHO has to be very active in helping companies and whatever, or consortium, to be able to produce vaccines very rapidly. And this again is a question of funding. So it means bringing together different countries who will be able to fund the COVAX. And the last point I'll make was that, and I know it's a kind of a political thing, but one of the issues of when the United States at least made a declaration that they would leave the WHO because of the handling, regardless of whether there was any kind of truth in that or not, that to me is a completely wrong approach to say if something is not working the way it should be, you're going to just abandon it. I mean, the basic thing is fix it, be in there and improve it. If you abandon it, you have nothing. And if you break that apart, you're basically producing a recipe for disaster. So I think the idea now, and hopefully the USA will join in strengthening the WHO, strengthening the information technology, and strengthening the trust in WHO, which I think is going to be a very important issue. And I'm certainly one of those who believes that all countries will collaborate in that. I don't think that any country will see that this is not in their interest, in all our interest, to really collaborate. So we need strong WHO leadership.
Well, that's very encouraging, because I do think that with all differences, you do see people cooperating in this campaign at the present time. I mean, all human life, people have differences of opinion, and we want to get them resolved. Now, we have about 2 or 3 minutes. Now, it seems we have, no, I don't think, I think we've probably answered this question. So, so I'd just like to sum up and say what a pleasure it's been to listen to. You have obviously
Thank you.
Together all these different disciplines which you have mastered in now coming to be an expert in this field. And I at least feel that you've answered all our questions very clearly, very thoroughly. And on behalf of everyone listening in, I'd like to thank you, Professor Green, very sincerely for joining us today.
Thanks so much. Thanks to all of you. All the best.
Thank you very much.
Okay.
Bye-bye.
Bye.